Welcome to the ECG Diagnostic Blueprint. This series is designed to help you master arrhythmia recognition by linking electrical tracings to actual cardiac physiology. On this title screen, we see a normal sinus rhythm with a heart rate of 72 BPM, a PR interval of 160 milliseconds, and a QRS of 90 milliseconds, all of which fall perfectly within normal clinical limits. To read an ECG, you must understand the paper it's written on. One small square represents 40 milliseconds, 1 millimeter, and one large square equals 200 milliseconds. Use the 300 rule for heart rate. Divide 300 by the number of large squares between R waves. Concepts like tachycardia, less than 3 large squares, and bradycardia, greater than 5 large squares, become visually intuitive here. Now map this to the heart's movement. The P wave triggers atrial systole. The start of the QRS marks isovolumetric contraction, where the mitral and tricuspid valves close, producing the S1 heart sound. Ventricular systole occurs during the ST segment, while the end of the T wave signals isovolumetric relaxation, marked by the closure of the aortic and pulmonary valves, the S2 sound. Let's define the normal. The P wave signifies atrial depolarization and should be under 120 milliseconds. The PR interval, 120 to 200 milliseconds, is critical. It represents the AV nodal delay, which, acting as a gatekeeper, ensures the ventricles have time to fill with blood. The QRS complex, 80 to 100 milliseconds, is ventricular depolarization. Watch for deep Q waves, greater than 40 milliseconds wide or greater than 1 millimeter deep. These are permanent scars of cell death from a past infarction. Finally, the ST segment and T wave represent ventricular repolarization. A prominent U wave here is a classic sign of hypokalemia. When facing a fast rhythm, greater than 100 BPM, use this logic tree. First, look at the QRS width. If it's narrow, less than 120 milliseconds, the signal is coming from above the ventricles, supraventricular. Narrow rhythms are then sorted by regularity. Regular, SVT atrial flutter, or irregular, atrial fibrillation/MAT. If the QRS is broad, greater than 120 milliseconds, the conduction is slow because it's occurring intermyocyte, outside the fast-conducting Purkinje system. These are dangerous ventricular rhythms, like VT or VFIB. Let's look at the narrow complex spectrum. Atrial fibrillation, characterized by an irregularly irregular RR interval and totally absent P waves. Because the atria are just twitching, blood stagnates, forming clots that can lead to ischemic strokes. Atrial flutter features a distinct sawtooth pattern caused by a macro reentrant circuit, typically in the right atrium. MAT, multifocal atrial tachycardia, an irregular rhythm where P waves are present but show at least 3 different shapes, frequently seen in patients with COPD or theophylline toxicity. Wolff-Parkinson-White, WPW, is caused by a short circuit called the bundle of Kent. This accessory pathway lacks the delay property of the AV node, leading to early partial ventricular contraction. On the ECG, this manifests as the delta wave, a slurred upstroke of the QRS, combined with a short PR interval and a broad QRS. These are life-threatening rhythms. Monomorphic VT shows uniform, wide QRS complexes. Look for the Josephson sign, a notch in the S-wave downswing, or capture beats to confirm it's VT. If there's a pulse, treat with amiodarone. If pulseless, you must defibrillate. Polymorphic VT, torsades de pointe. The QRS appears to be twisting around the line. This is often triggered by QT prolongation from electrolyte crashes, low K+ or Mg2+, or certain drugs. The gold standard treatment is IV magnesium sulfate. Think of these as walking styles. First degree, consistent but slow walking, PR greater than 200 milliseconds. Second degree Mobitz 1, Wenckebach. Steps get progressively further apart until a trip occurs, the dropped QRS. Second degree Mobitz 2, walking is perfect, but you suddenly miss a step. This is highly unstable and can lead to a complete crash. Third degree, complete AV dissociation. The atria and ventricles beat independently. Clinically, this produces canon A waves in the neck vein. Time is myocardium, minutes. The earliest finding is the tall-tented T wave. Minutes to hours, you see ST elevation, often called the Pardee sign or tombstone appearance, signifying active injury. Hours, the deep Q wave appears, indicating established cell death. Days. As the ST segment normalizes, the T wave inverts, marking the evolution of the infarct. Leads tell you where the heart is dying. Anterior wall. LAD. Leads V1, V4. Lateral wall. LCX. Leads I, AVL, V5, and V6. Inferior wall. RCA. Leads 2, 3, and AVF. Note that inferior MIs are uniquely associated with bradycardia and vomiting due to irritation of the adjacent vagus and phrenic nerves. Posterior wall, shown by reciprocal changes, ST depression in V2 and V3. This matrix differentiates the three ACS types. While all present with chest pain at rest, they differ in the lab. Unstable angina has an abnormal ECG but normal biomarkers. NSTEMI and STEMI both show elevated biomarkers, but only STEMI shows the transmural ST elevation requiring immediate reperfusion. Enzymes rise and fall at different speeds. Myoglobin is the fastest to rise but is the least specific. Troponin IT is the gold standard because it is highly specific and stays elevated for up to 14 days. CKMB is your reinfarction marker because it drops quickly. If it rises again after 48 hours, the patient is having a second MI. Remember best MOAN, beta blocker, enoxaparin, statin, and thrombolysis, if non-PCI capable, paired with morphine, oxygen, aspirin, and nitroglycerin. The clock is ticking. The goal for primary PCI is a device time of under 90 minutes from first medical contact. Potassium is the heart's electrical stabilizer. Hypokalemia, less than 3.5. Causes ST depression and prominent U waves. It puts the patient at risk for torsades. Hyperkalemia, greater than 5.0. This is a medical emergency. You will see peaked T waves, the earliest sign, progressing to a wide QRS and eventually a sine wave. This leads to diastolic arrest. Treat immediately with IV calcium gluconate to stabilize the myocardium. In tamponade, fluid in the pericardial sac crushes the heart. On the ECG, look for electrical alternans. The height of the QRS changes beat to beat because the heart is physically swirling inside the fluid. Clinical signs include a low voltage ECG and pulsus paradoxus, a significant drop in blood pressure during inspiration. Three major culprits to watch for: Brugada syndrome, a cove pattern's T elevation in V1, V3 caused by an SCN5A mutation. HCM, hypertrophic cardiomyopathy, massive septal hypertrophy causing deep narrow Q waves and voltage criteria for LVH, deep S in V1+, tall R in V5 greater than 35 millimeters. ARVD, look for the epsilon wave, a small M-shaped notch right after the QRS complex. When a patient is pulseless, the first question is the rhythm shockable? Yes. Ventricular fibrillation VF or pulseless VT private. Deliver a 200 J shock immediately. No. Asystole or P. Pulseless electrical activity. Do not shock. You must perform CPR and give epinephrine while hunting for the reversible causes. To save a patient in P, you must fix the underlying cause. The H's: hypovolemia, hypoxia, acidosis, potassium issues, hyper/hypo, and hypothermia. The T's: toxins, tamponade, tension pneumothorax, and thrombosis, either a massive PE or a massive MI. Finally, we synthesize these into cases. Case I. A young woman collapsing while rushing upstairs with a narrow complex tachycardia is a classic AVNRT. Treat with vagal maneuvers or adenosine. Case 2. A diabetic male with bradycardia and hiccups has an inferior wall MI. Crucially, nitrates are contraindicated here because they crash the preload. Treat with IV fluids instead. Case 3. A sudden pulseless collapse post-MI is likely VFIB. This is a shockable rhythm requiring immediate unsynchronized defibrillation. Thanks for watching.